Hi, I'm Susie with EMS World, and with me today is Dr. David Boyd. Dr. Boyd, I understand you're retiring after quite a career, and during the FICAMS meeting this morning, you were referred to quite a few times as father of EMS systems. Can you give me an idea how that came about?
Well, first of all, I'm retiring from the federal government, but I'm not retiring from the field of EMS. The father of EMS, it comes in various commodities. Father of trauma systems, father of trauma and emergency medical services systems, and the like, but there's always a father component in there. I think it's fair because the systems idea really started with us in Illinois, and from that we propagated a lot of other enthusiasts for systems, and first in Chicago and then in Illinois. And then as the national director, we again fostered another cadre of activist EMS people, which included EMTs, first responders, trauma nurses, trauma nurse coordinators, emergency physicians, trauma surgeons, hospital administrators, and don't forget politicians. We had that whole cadre of people that were interested in improving trauma and emergency medical care for their communities, and they needed a teacher, and that was me initially. And then as we taught other people how to set these programs up, we developed a whole cadre of effective teachers in the area of trauma, cardiac, burn, pediatric care, and of course the technical aspects of ground transportation and helicopter transportation. What we had done in Illinois, what we had done initially at County Hospital, we transposed to the system in hospital system in Illinois and then nationally. What we did also in Illinois is we would develop the first paramedic program, not the first paramedic program in the country, but modeled after Seattle and Los Angeles and New York and some other places, Nassau County, New York, and other places. We found that we would establish this through a state program. The state program then needed a responsible entity, and that turned out, as the legislation was written, that I was now going to be responsible for an estimation of 20,000 paramedics across the country. And I said, whoa, what is this all about? So I got the co-developer of this program in Illinois, Dr. Stanley Zidlow, who had actually started a program initially in the Arlington and the Buffalo Grove, those 8 communities up by the O'Hare Field. And I said, well, we got to do something about this. And so we got the legislation passed, and then when we wrote the regs, we actually wrote these terms that everybody uses now: medical control and accountability, online supervision, offline supervision, treatment protocols, systems protocols, operational protocols, and that all came from that basic program, because I found out that I was going to be responsible someday if I'd have stayed in the job for 20,000 paramedics, which is just a terrible way to manage a program, and one that.
So I understand the you were on Capitol Hill and you were trying to explain this new whatever EMS, and that was kind of a challenge to get the senators in Congress.
Well, actually, it wasn't. I just needed 3 minutes. I testified for the Rogers Committee in 1972 for the EMS Act of '73. Prior to my short 2 minutes at the end of the hearing was every politician east of the Mississippi that was trying to convince the congressman that they needed subsidy support for mortician and untrained and unsupervised and unprofessional services. It was looking back on it, it was a comedy that could have been a disaster. In my 2 minutes, I said, look, these gentlemen here are sincere, but they're taking us in the wrong direction. What we need is a system for trauma and all other kinds of emergency care, a system that includes all types of transportation, ground, air, telecommunications, and the like. And we have a program like that in Illinois. It's now 4 years of age, and I would be willing to share that with you. Congressman Rogers asked me to stay over, and actually I did. I stayed in Washington for 2 days, and I actually helped write, and I wrote the basic elements of the Emergency Medical Services Act of 1973.
Give me an idea what exactly the EMS Act of '73 was.
Well, it was the first national initiative for emergency medical services programs of any kind. The Department of Transportation had a funding mechanism through its National Highway Traffic Safety Administration, it was called in those days the 402 funding, to purchase ambulances, support some EMT training program, and some communications. But that wasn't the system. The systems grant was modeled after what we had done in Illinois, which took on a regional basis, multi-county regional basis, all over the state, a wall-to-wall system that was accountable for every accident victim, every heart attack, every child drowning, and neonate and other problem that might arise in a coordinated systems way. Now, what I did is I took that to Washington, and the first thing we did when we sat down to write the legislation is we established there had to be a lead agency. There had to be a lead agency, which eventually turned out to be the state health department, that would coordinate all these programs, much like we did in Illinois, and set the model for that. But the two components of the bill that were most important was the systems component, which were all of the clinical entities. So you had to have, if you were going to get federal money under this act, you had to have a trauma plan that made sense. You had to have a burn and cardiac and neonate, perinatal transport, poison control, and behavioral emergency plan. I mean, these had to be real. They had to go into action right away. But they were the systems, the 6 systems as we called them in those days. And the components. Prior to my formulating this bill, there was a lot of controversy between what's more important, is the ambulances or the hospital. If you don't have the radio, you can't call the ambulance, you can't, and that sort of banter went on and on and on. What I talked the Congress into doing, the grant writer, the law writers to do, was to make these components, and that's where the 15 components of the EMS Act came from. So manpower, training, communication, transportation, critical care units, hospitals in general, disaster planning, and the like came from. So what you did if you got a grant from us, and later I was appointed by President Ford to be the national director to administer this bill, if you were going to get money from us on a regional basis, we had each state send in its regions, so we ended up with 304 wall-to-wall, corner-to-corner regions across the 50 states in Alaska, and the territories all were part of this program. Now, what we did was that within that region, you sent a grant request in for that region, you had to have a trauma plan, you had to have basic ambulances, EMT training, and a radio communication system. As you went through the system, then you would advance to cardiac and ALS and medical control and the like. So that's how we established the money, established the program. The funding for that was generous in those times. We had a budget of about $30 million a year, and we ran that program through the Ford, Carter, and then not so well during the Reagan administration because he closed us down in the second year of that year. But the program then continued on by the lead agency, these health departments that are now the EMS offices in every state and major city. New York and Chicago have their own, of course, but so does the state. So the coordination and the effectiveness of the overall program is then maintained because the clinical needs of trauma patients or burn patients and the like, and the infrastructure, which is provided by the people that are trained in the transportation, the ambulances and the helicopters, all fit into an organized plan to meet those patient needs on a regional basis. And basically that's still out there. It's amazing the longevity and the enduringness of this program. Now, how much did it cost the taxpayer? I figured we spent $300 million. There are 300 million people in America about this time. That's $1 per head, but we did it over a 10-year period, so it's 10 cents. So this has to be the most cost-effective federal program that was ever done, and is still out there.
Wow.
It is still out there.
So what agency or what agency have you been with, and you're retiring from? I understand.
Well, what I did then is I left the federal government. It's private consulting. I did a lot of international work, and that was quite interesting to see the difference is how much could we transpose our system into other countries. The transposition to Canada was, of course, not difficult because the societies are very similar. But as you get further and further away, even to Europe and then of course the East and the Middle East and places like that, the society is very different. The technical components are the same in terms of EMT training and the like, but how you put the program together is quite different and highly influenced, just like ours is, but we don't appreciate it because it's our program here in America. So it was really educational, and you know, and I enjoyed it. What I did then, because I always wanted to return to clinical surgery, is I returned to work within the Indian Health Service. The Indian Health Service had been part of our program early on when I was a federal agent. We were actually in the same overall agency, and so I knew the program. So I became an emergency physician out at Rosebud in the Sioux Reservation in South Dakota for a couple of years, and then I was the surgeon and then clinical director at the Blackfeet Community Hospital in Browning, Montana for about 12 years. I didn't go permanently. I traveled from my home here in Maryland out and did the surgery and came back. But in both of those places, I was the EMS director, of course, and doing that sort of thing. But actually, I saw things from a different perspective, and like I was at Browning, Montana, at the Blackfeet Reservation. I actually was honored by having the tribe honor me with special names. In Sioux, my Indian name was Lone Buffalo. And at Blackfeet it was Pita Ana, which was Flying Eagle. I think that's because I was flying in and flying out all the time.
And that's what agency you're leaving?
Yeah, and then what I did is I went, that was in the Indian Health Service. I was working back in the federal government, working for the Indian Health Service. So what I did, rather than retire some 6-7 years ago, I said, why don't I come to the central office and see if I can improve trauma care in Indian country by working out of the Indian Health Service. And that's what I've been doing until next Friday. That's what I will be doing. And the goal there was to bring the Native American trauma and EMS system into the 21st century. So regionalization, just like we had done before. Technology now, the CT was necessary. All trauma now is CT dependent. The old system was non-CT, computerized tomography, of course. And the new system is CT. The diagnostic accuracy for all kind of trauma is good. So what we've done is we were able to put 10 brand new high-powered CTs in 10 of our hospitals. We were able to hook up in the Navajo area, in Hopi and Zuni in the Southwest in these years, hook them up to university and advanced community medical centers, so they're immediate read by neurosurgeons and trauma surgeons for immediate advice and the like. So that's really state-of-the-art. So we went from the 20th century to really pushing state-of-the-art in the Southwest, and of course that has to be extended elsewhere. The other thing that we found out was the old teletrauma, which used the video equipment like you're holding in your hand, we found out that didn't work for us in Indian country. We have a single family practitioner, maybe a nurse, always a nurse, but maybe a clerk, trying to take care of a calamity of 3 or 4 or maybe 6 kids that got turned over in a pickup truck. And the issue was, who's going to do your job? Who's going to hold the video? And the answer is nobody. And at the same time was at the other end of the spectrum at the universities, who was going to break scrub to go down and read. So we invented there, through the help of Dr. Peter Ree. Dr. Peter Ree is the trauma surgeon and director of the program at the University of Arizona in Tucson. And he is probably known to many of you because you saw him during the shoot-up of the Congress lady in Tucson and others. He was a spokesperson for the program. So he's probably more recognizable than me up till this interview. But anyhow, Peter and I put together this idea of using the smartphone. So now we use a smartphone with, I don't know, all the technology that goes with that. So it's patient record protected and the like from an outlying hospital into the regional center. So again, that's state-of-the-art. So we took us a while to get there in the Indian Health Service, but we've really been on warp speed here the last couple of months to be modern. In fact, probably more modern than many rural areas. So some of your visitors would probably be interested in learning about those technologies.
Okay, well, thanks a lot for your time today. Appreciate it.
Thank you.
Okay, take care.